So this is the first lecture on muscles, lecture 15. We'll be covering the back, trunk, head, and neck. So this is an overview slide I like to use because I think it shows the big picture of everything we're going to end up talking about with muscles. So if we look up at the very top left-hand corner, we see the biceps brachii muscle, and we see it from one side of the muscle to the other, from both points of attachment. If we were to take a transverse section of that muscle, if we were to cut it open and look inside, we would notice that muscle is bound together by connective tissue. When we pull out one of those connective tissue bundles, we notice that it is made up of several different muscle fibers. Each muscle fiber has an even smaller unit contained within called a myofibril. And myofibrils are what give us that striated appearance on skeletal and cardiac muscle, that light and dark banding pattern. Because when we pull a myofibril apart into the smallest unit of muscle contraction, we have a sarcomere. The sarcomere contains the two main proteins of muscle contraction, myosin and actin, and there are other accessory proteins that we'll also talk about. So first of all, when we start to describe musculature, there are four words that I'll be using over and over and over again. They are extrinsic, intrinsic, origin, and insertion. When we talk about muscles being extrinsic or intrinsic, you could also say, are they necessary to the region we're studying, or are they unnecessary? Extrinsic muscles originate outside the region we're studying. So today, for instance, we're studying the back. If a muscle is extrinsic to the back, it may appear on the back, but it's not necessary to the functioning of the back. The back is part of the torso of the body where we know our limbs are anchored there, so many of the muscles that appear on the back are actually for the limbs. Intrinsic is the opposite. It is an essential muscle. It usually originates and inserts in the region of study. So today again we're studying the back. If we have an intrinsic back muscle, it is necessary for the functioning of the back. Now we've already mentioned origin and insertion. I'm not going to require you to know the origin and insertion of every muscle that we study, but based on these two definitions here, you should be able to look at any muscle, whether you know what that muscle is or not, and tell me which part of it is the origin and which part is the insertion based on these definitions. The origin of the muscle is the less movable part. It's usually attached to the fixed part of the skeleton, which is the trunk of the body, which includes the the thorax, the abdomen, the pelvis, the back. These are all parts of the trunk. The insertion is the attachment of the muscle to the more movable part of the skeleton. So many muscles will start on the trunk, and then they will insert onto a limb, for instance, which is a more movable part. So if I were showing you a muscle and you could see that one part was clearly on the trunk, the other part clearly on a limb, you should be able to identify the part of the muscle on the trunk as the origin and the part on the limb as the insertion. Starting with the extrinsic muscles of the back, there are four major muscles: trapezius, latissimus dorsi, levator scapula, and the rhomboids group. Why are they extrinsic to the back? Because again, although they appear on the back, they are for the upper limbs. They connect the upper limbs to the trunk of the body, and they control the upper limbs. So these four muscles would have their origin on the trunk and their insertion on the upper limb. Starting with the most superficial of the four, and superficial meaning if we remove the skin, these are the first muscles we would see: trapezius, and then you have a latissimus dorsi on the right and latissimus dorsi on the left. That's what this number 2 is for. Trapezius is coming from the word trapezoid. Okay? Trapezoid is like a diamond. So if we look at the trapezius muscle here, we see that it takes on a diamond shape. We see the majority of the muscle lying on the trunk of the body, but then it inserts onto the upper limbs. Latissimus dorsi sits adjacent to trapezius and wraps around the rib cage, again, or originating on the trunk, and then it will go and insert on the upper limb. You have a latissimus dorsi on the right and a latissimus dorsi on the left. If we were to remove latissimus dorsi and trapezius, we would find two other muscle groups, the levator scapula and the rhomboids group. So if we look at the word levator scapula, levator, that's to levitate or to rise up. And your scapula, as you know, is your shoulder blade. So anytime you shrug your shoulders, you're elevating or you're levitating your scapula. So shrugging your shoulders uses levator scapula. And as you would suspect, we see one part of the muscle attaching to the scapula and then goes up into the neck towards the skull. That's levator scapula. You have one on the right and on the left. The rhomboids group, again, a rhombus is a square. It's coming from the shape name. Rhomboid is similar to a square. You have rhomboid major and rhomboid minor, and this is a theme you'll see repeated throughout muscles are major and minor. Major is usually larger and minor is usually smaller. Another rule that usually plays with major and minor is that the minor is usually more superior and the major is more inferior. That does not always hold true, but in most cases it will be. And here's where we find our rhomboids. Rhomboid major is the larger, more inferior muscle. Sitting right above it is rhomboid minor. And again, over here would be the trunk of the body, inserting onto the scapula, which would be part of the upper limb. Some accessory muscles, these are still extrinsic to the trunk, and they are accessory to respiration, are called serratus posterior superior and serratus posterior inferior. These two muscle names are indicating the shape of the muscle and its location. Serratus is coming from the word serrated. A bread knife is serrated. A serrated edge is a jagged edge. And the serratus muscles are jagged when you look at the way that they interact with their tendons. So serratus describes the shape of the muscle. Posterior is indicating which side of the body. Superior is more towards the head, and then serratus posterior inferior is going to be more towards the feet. So again, if you remember what each one of these words mean, frequently they tell you what the muscle looks like and where it's located. Again, the serratus posterior muscles are accessory to respiration. If we go even deeper into the back, we will finally hit the intrinsic back muscle layer. Again, intrinsic meaning that they are necessary to the functioning of the back. The first group are the splenius group, splenius capitis and splenius cervicis. The word splenius means bandage, and of course thusly named for their appearance. They are large, flat, broad muscles, as if somebody were wrapping a gauze bandage several times around. It would be large, broad, and flat. The splenius muscles originate, both splenius capitis and cervicis, from lower cervical and upper thoracic. So we're talking about C6, C7, T1, T2. That's where they're originating from. The insertion is different for capitis and cervicis, and that's where you're getting capitis and cervicis from. Splenius capitis. Okay, if I decapitate you, to decapitate is to take someone's head off. Capitis is indicating that that muscle goes from the lower cervical and upper thoracic vertebrae up to the skull. Splenius cervicis. Cervicis comes from the lower cervical and upper thoracic, originates from, and inserts right back into the upper cervical vertebrae. So that's where you're getting capitis and cervicis. What's their action? What do they do if you contract them? If you use both, they extend the head. If you put your chin on your chest, you flex the head. When you pull the head straight back up to 180 degrees, that's extending the head. If you contract only the splenius muscles on the right side, you're turning the head. When you look to the right, you're using your right splenius capitis and cervicis. When you look to the left, you're using your left splenius capitis and cervicis. And here's a picture. In red, we see splenius capitis coming from these lower cervical, upper thoracic, and going right up to the skull. In fact, goes right up near that mastoid process. Splenius cervicis, on the other hand, is coming from these lower cervical, upper thoracic, it comes out and it's going to duck right back in and attach back to these cervical vertebrae. So we are unable to see all of splenius cervicus in this picture. More intrinsic back muscles, another main group of intrinsic back muscles, are called the erector spinae group. These are extensors of the vertebral column. Again, if you bend over and touch your toes, you're flexing. When you stand straight back up, you're extending. The three erector spinae groups, and you want to know the full name of each muscle. Okay? Erector spinae spinalis is the smallest and most medial of these three columns. Erector spinae longissimus is in the middle, so it's intermediate. And erector spinae iliocostalis is the most lateral. When we look over at this picture, here's erector spinae spinalis, erector spinae longissimus, and then the most lateral is erector spinae iliocostalis. A lot of students like to remember them iliocostalis, then longissimus, then spinalis. ILS, I love spaghetti. Iliocostalis, longissimus, spinalis, and they're all erector spinae. So don't forget the erector spinae part. Oh, something's mad at me. Let's see if we can get this back on track. Oh, it's because I clicked on the picture, I see. Okay. Continuing on, the erector spinae muscles. So as each of those three columns ascend the back, so as they're coming up from your pelvis up through your vertebral column, each column's fibers are going to overlap, and that helps to stabilize the vertebral column. When you want to think about blood and nerve supply of each, we're finding that the blood and nerve supply originate at each vertebral level. So as each one of the columns passes, let's say T6, the blood supply and the nervous supply from T6 come out just there, and then they move up to T5 and T4, and that's how they're being supplied. Where do they originate from? All three are going to originate from something called the broad tendon, and the broad tendon is on the posterior surface of the sacrum, and also it extends up to the posterior edge of the iliac crest. We'll even see the broad tendon coming in as far as the transverse processes of T11 through L5. The other thing that's important to recognize, it gets a little tricky with origin and insertion, as each column, in column we're talking about spinalis, longissimus, and iliocostalis, comes up the back, the origin and insertion of some of the fibers will change. So it's not a column in the strictest definition of the word. When we look at insertion, we find that all of them, again, are going to originate from the broad tendon. Spinalis is going to come up, and it's going to insert in the spinous process of the vertebrae from lumbar to thoracic. So that's where we have the insertion of spinalis. Again, these are intrinsic muscles, so we would expect to see them originating and inserting on the back. Longissimus, the middle column, goes from the broad tendon all the way from your the posterior pelvis and sacrum to the mastoid process. So it's coming, some of them come all the way up to the skull, and the transverse process of the thoracic and cervical vertebrae. Longissimus by far is the longest. So that's how it's getting that longissimus. It's the one in the middle, it's also the longest. Iliocostalis, that's telling you where it starts and where it finishes. Ilio is iliac crest, costalis, costal. Costal means rib. So iliocostalis inserts on the angles of the ribs and the transverse processes in the cervical region, and I'll show you a picture of that. When you use all three muscles together on both sides, you can extend the vertebral column. If you turn the whole trunk of your body to the, not turn, but if you bend from your hip over to the right side, that's going to be flexing, and also to the left side, that's using only one set or the other. So let's just go back and look at that picture again. Here's the broad tendon. It's on the posterior sacrum and that iliac crest. There's iliocostalis going from the iliac crest and it fans out and inserts into the angles of the ribs. If we look at longissimus, it is by far the longest. We can trace it all the way up to the mastoid process. And then spinalis, we see, is the shortest, it's the smallest, and the most medial, closest to the spine. That's how it's getting its name. If we move around to the anterior thoracic wall, there's one group of muscles most people are familiar with called the pectoralis muscles. We have pectoralis major and minor. In this case, it doesn't work out the way the rhomboids did with superior and inferior. Pectoralis major actually sits on top of pectoralis minor. It is more superficial than pectoralis minor. So here's pectoralis major. If we cut pectoralis major away, we will see pectoralis minor, and then we'll talk after those about serratus anterior. So pectoralis major, that's your pec muscle. It makes up the bulk of the chest muscle on both males and females. It is very thick. It takes on a fan shape. Again, if you remove pectoralis major, underneath you will find pectoralis minor. Pectoralis minor is deep to pectoralis major, and it's smaller and more triangle-shaped. The serratus anterior. Okay, we had a serratus, another serratus group. They were serratus posterior, the ones accessory to respiration. If we look at the serratus anterior muscles, they're also called the winged scapula muscle or the boxer muscle. In order to describe their position, they insert into the entire anterior length of the medial border of the scapula. So you have to visualize your scapula. Okay, go to the medial side, the side closest to the spine. The entire anterior length of that border is the insertion of that muscle. The origin is actually on to the ribs. Why do we call it the boxer's muscle? Because if you look at boxers, they have a highly developed serratus anterior because of protracting the scapula. If you take your arm and you put it into a punching motion, the muscle that is allowing you to protract your scapula or to bring it from the posterior of your body to the side of your body is, as when you throw a punch, is serratus anterior. Again, serratus, it's that serrated edge. You see that sharp point, that jagged edge like a serrated knife. Intercostals are another group that are on the anterior thoracic wall and actually wrap around back to the posterior thoracic wall. Inter means between, again, costal means ribs, so the word intercostal is indicating that the muscles occur between the ribs. Two sets, external intercostals and internal intercostals, and they are thusly named because the external are more external and the internal are more internal. External intercostals, if you look closely at the muscle fibers, those muscle fibers are running in one direction. The internal intercostal muscle fibers are running in another direction. That's where we're getting hand in your front pocket. When you stick your hand in your front pocket, the angle of your arm is the same way that the muscle fibers of the external intercostals are running. The other giveaway for an external intercostal is that on the anterior rib cage, the external intercostal muscles disappear and they are replaced by a clear membrane. So the intercostals that appear closest to the sternum are not external, they're internal. And I'm going to show you a picture. The internal intercostals, their muscle fibers run as if you were going to put your hand in your back pocket. And they also have a membrane on the posterior. So the intercostals closest to your spine have to be external. These muscles are intrinsic to the thoracic wall. They are absolutely necessary for respiration. They have both their origin and insertion on the thoracic wall. Here are the external intercostals. They sit over top of the internals. If we look at the muscle fiber direction, we see it's running towards your front pocket. These are front pocket. Again, notice they do not come all the way around to the anterior to the sternum because right here would be a clear membrane. If we switch to the internal intercostals, notice again the muscle fiber running towards the back pocket, running towards the posterior, and as it approaches the spine, we see no more internal intercostals. There would be a clear membrane there. While we're talking about respiration and muscles, it's of note to talk about the diaphragm. The diaphragm is the chief muscle of respiration. If your diaphragm went down, we'd be in trouble with breathing. It's dome-shaped. It's called musculotendinous because it is both muscle and tendons, and it is the official partition that separates the thoracic and abdominal cavities. So if I were to ask you what structure separates the thorax from the abdomen, the answer would be the diaphragm. Everything above the diaphragm is in the thorax. Everything below the diaphragm is in the abdomen. Diaphragm has two domes. They curve superiorly, so up towards the head, into a right dome on the right side and a left dome. The right dome appears higher because of the right side of the liver being larger. The level of the dome can vary depending on a few things. Respiration. Every time you inhale, those two domes dive inferiorly. Your posture. If you're sitting up versus slouching, that's going to change the level of your dome. The size of the diaphragm itself and the degree of distension of the abdominal viscera. Distension is when the abdominal viscera are pushed towards the anterior. This would take with it that diaphragm, and it could change the level of the domes depending on how far to the anterior the abdominal viscera were being distended. There are three openings in the diaphragm, so not a lot of structures can pass from the thorax to the abdomen, but there are three, and they have to pass through the diaphragm. They are the caval foramen, the esophageal hiatus, and the aortic hiatus, and those are in order from the most anterior opening to the most posterior opening. So let me orient you to this picture. We are looking up at the bottom of the diaphragm. So we are essentially sitting in your abdomen, and when we look up, we see the diaphragm. Here's the xiphoid process, so this we know is the anterior. Here's the vertebral column, so this we know is the posterior. This is the caval foramen, the most anterior opening. There's the esophageal hiatus in the middle, and the most posterior opening is the aortic hiatus. The caval foramen is essentially almost in the center of the diaphragm. It's for the inferior vena cava, the very large vein that's coming up towards the heart. Now the inferior vena cava actually sticks to the diaphragm, and what that does is it helps facilitate blood flow, because every time you breathe, every time you contract your diaphragm, it closes that inferior vena cava, and every time you exhale, it opens. So it acts as another pump, a second pump, helping to get blood from your toes up to your heart against gravity. The esophageal hiatus is for the esophagus. And when we look up at the bottom of the diaphragm, and I'll point this out on the picture again, muscular fibers from the diaphragm are crossing each other inferior to the esophageal hiatus. And this is one mechanism in a long line of mechanisms to make sure that you cannot eat and breathe at the same time. Every time you swallow, you have to stop breathing for a minute, because when you breathe, when you inhale, it will constrict the esophagus because the diaphragm will be contracting. So again, just another in a long line of mechanisms to make sure you don't eat and breathe at the same time. The aortic hiatus is the most posterior opening. Not a lot to say about it. Aortas have much more connective tissue, and so the blood flow is not affected by the movement of the diaphragm. Your diaphragm can constrict and contract and release all day long. It will not affect the blood flow through the aorta. So again, we're sitting in the abdomen looking straight up at the bottom of the diaphragm. We see the caval foramen. This one is attached to the diaphragm. Here it is in the central tendon. Here's the esophageal hiatus for the esophagus, and there's where the muscle fibers cross over, so that every time you inhale, it would actually constrict that esophagus. And then finally the most posterior opening, the aortic hiatus, unaffected by the movement of the diaphragm. The last thing we want to talk about are muscles of mastication and facial expression. So this is our laundry list of muscles of facial expression. Platysma, zygomaticus major, orbicularis oculi, orbicularis oris. If we start with platysma, it's an incredibly superficial muscle. It helps you to depress your jaw, and you can see it's running from the mandible across the neck down into the clavicle, the shoulder area. Now for each one of these muscles of facial expression and mastication, I'm going to give you the cranial nerve that supplies it. We're going to find an easy pattern. I do want you to know that, but there are some differences I want you to recognize, and we're kind of planting a seed to start cranial nerves here in a couple of lectures. So platysma is supplied by the facial nerve, which is cranial nerve number 7, indicated by these Roman numerals. Zygomaticus major. There is a minor. We're not going to study it. Zygomaticus major moves the corner of your mouth superiorly and posteriorly, as if you were smiling. That's what zygomaticus major does. And by the zygomaticus, we should all remember, from the skull, it's going from the corner of the mouth up to the zygomatic arch. That's where you're getting zygomaticus. It too is supplied by the facial nerve, which is cranial nerve number 7. If we look at orbicularis oculi, if something orbits, where you're getting orbicularis from, it goes around. Oculi is the eye. So orbicularis oculi is a round muscle that encompasses the eye. This is the only muscle that acts to close your eyelid. So anytime you close your eyelid, you're using orbicularis oculi. It is supplied also by the facial nerve, cranial nerve number 7. You don't have to worry too much about these branches. Orbicularis oris, again, orbicularis is coming from orbit, going around. Oris is like oral, it's the mouth. So this is a muscle that completely encircles the mouth. It's called the sphincter of the mouth. The kissing muscle, anytime you pucker your lips, you're using orbicularis oris. And again, cranial nerve number 7, the facial nerve. So we're starting to see a pattern arise. Switching from muscles of facial expression to muscles of mastication. So masticating is eating. Anytime you chew, these are muscles that help you. Temporalis, thusly named because it covers the temporal bone. It elevates the mandible, so anytime you close your mouth, you will be using temporalis. When you close your mouth and clench your jaw, and if you put your fingers up on your temples, you can feel temporalis contracting. Now this is a muscle of mastication, and it is supplied by a cranial nerve called the trigeminal nerve, nerve number 5. So far we've seen all the muscles of facial expression be supplied by cranial nerve number 7, the facial nerve. Our first muscle of mastication is supplied by the trigeminal nerve, cranial nerve number 5. The masseter muscle, okay, covers part of the mandible. It also helps to close the jaw and chew. And again, if you close your jaw and you clench it and put your fingers at the corner of your mandible, you will feel the masseter muscle. Very important for mastication, for chewing. Also supplied by the trigeminal nerve, number 5. Oh, I did it again. Okay. The pterygoids, and if you remember all the way back to the sphenoid bone, we had the pterygoid process. That's where this is coming from. You have a medial pterygoid and a lateral pterygoid. They help to close the jaw. Okay, they help with side-to-side movement. So every time you chew, it's not an up and down movement. It's a circular movement, and part of that is facilitated by the pterygoids. Okay, they are supplied by the trigeminal nerve. In this picture, here's the medial pterygoid, and if you remove it, you can see the lateral pterygoid. These are very, very deep muscles of mastication and are unable to be seen on the models in lab, so these are only pictures of them. Here's the lateral pterygoid. The medial pterygoid has been removed, and we see the lateral pterygoid helps to open the jaw, also helping to move side to side, and supplied by the trigeminal nerve. The last one is the buccinator. Okay, 2 C's. First C is hard, the second C sounds like an S. Buccinator. It assists with mastication, so it does help you chew because the cheeks coordinate the chewing movement, but it also seems to fit with facial expression. So here's your buccinator muscle. If you were to suck in your cheeks, the part that gets sucked into your mouth is the buccinator muscle. Or if you have dimples, dimples appear right over the buccinator muscle. It helps to flatten your cheek, pulls the corner of your mouth posteriorly, and here's why we mostly think it fits with facial expression. Notice it's supplied by the facial nerve number 7, similar to the rest of the muscles of facial expression. So in general, the muscles of mastication are supplied by the trigeminal nerve number 5, and the muscles of mastication, or the muscles of facial expression, are supplied by the facial nerve number 7. And we have the buccinator, which seems to fit into both categories.